My name is Ijoma Obunia, a DMP student of Bradman University. This is a presentation of my proposed innovation. Many elderly Hispanic between the ages of 50 to 75 years is only eloquent in their native language. They are referred to as limited English proficient patients, LEP. You see me use LEP more as I go on. LEP is limited English proficient. As a result, they are disenfranchised due to the language barrier, which often necessitates for an interpreter. In urgent medical cases, ad hoc interpreters, who are often family members or are AMAs, act as interpreters between the patient and the physician or provider. However, the government of New South Wales policy stipulates a standard procedure where professionals such as bilingual interpreters are invited to offer interpretive services under such circumstances. This presentation is an innovation proposal on whether bilingual interpreters will help to enhance medication adherence among the patient population. The proposal seeks to examine my PICO question, which is, in Spanish-speaking diabetic individuals 50 to 75 years old, would the use of bilingual interpreter call during provider visits compared to utilizing family members as interpreters improve medication adherence over a 3-month period? Description of the problem. This slide tends to answer all questions pertaining to the problem the innovation will solve, what the problem is, where the problem occurs, who is affected, and what could be the difference if the problem is solved. The innovation project will reduce the problem of miscommunication, misunderstanding, misinterpretation, misdiagnosing during patient visit, and reduce incidence of error. The problem is improving medication adherence over a 3-month period in Spanish-speaking population using professional interpreters. The problem occurs in healthcare centers. The population affected is the Spanish population known as the LEP. Then the last thing here is what will be the outcome if the problem is solved? If the problem is solved, it's going to reduce incidence of error. Time with seeing LEP patients will be minimized. Patients will have confidence and belief in the provider. Adherence will no longer be an issue because patients understand fully the consequences of their non-adherence. While ad hoc or family interpreters are commonly used, they lack the requisite professional skills to help in the exchanges between patients and providers. Policy changes have also been made to promote the use of professionals like bilingual interpreters to assist in communication between these patients and the providers. Using bilingual interpreters would help enhance the quality of care given to patients in management of their conditions. Charles Stetson, Grossman, Haag, the innovators' prescriptions, states that healthcare is unaffordable because regulators have not permitted business innovation in healthcare industry. Currently, there are no elaborate systems that are designed to address the challenges presented by language barriers in the administration of health services to LEP patients. Patients who need the services are not aware of the importance of an interpreter as they receive health services. As a result, policy changes in New South Wales have been enacted to promote the use of professionals like bilingual interpreters to assist in exchanges between these patients and their providers as a standard procedure in the clinical setting. Most of LEP patients, including elderly Spanish-speaking diabetics, do not seek for insurance to cover for language assistance services given their lack of awareness of the significance of interpreters. Insurance, on the other hand, are conflicted on such services. Are conflicted on the other hand on if such services should be considered as a benefit, and if so, the metrics of what linguistic translators would present. Facilitation of active management becomes almost impossible for patients who have no close careers, as well as a comprehensive insurance to cover for that translation services. Additionally, the financial capability of the elderly LEP patient is often a limiting factor. These challenges continue to occur despite the fact that diabetes management requires close collaboration between patients and healthcare providers, as well as close monitoring in that regard. There is limited research that's been carried out on the financing of linguistic assistance services. There is scanty research documented on the cost associated with administration of linguistic services cumulatively, and the attempts put forward to avoid the cost incurred as an impediment to access to the services. The efficacy of linguistic intervention in the administration of healthcare is comprehensively covered. It's not covered. It's not comprehensively covered. This is by Jacobs et al. Based on the study by Jacobs et al., the prevalence of diabetes was highest among the third generation of the Hispanics, among the second generation Mexican Americans, and finally the first generation. While the preferred language did not present a significant difference in the presence of diabetes, the levels of education varied across the generation segmentation. Senthil and Brown, 2012, conducted a research to examine health literacy, health status, and English proficiency of Asians, Latinos, and other ethnic or racial groups in California. The study found that LEP patients with low health literacy and low English proficiency had the poorest health status. Having LEP is associated with greater vulnerability compared to having low health knowledge, but with proficiency in English. The currently utilized solution for language interpretation challenges facing LEP patients is ad hoc interpreters or family members. The use of ad hoc and family members services has an opportunity cost in favor of the staff time taking interpretation rather than perform their primary responsibilities. While doing my innovation, I collaborated with Dr. Derek Butler, my MD, and the Chief of Medical Officer, Dr. Mann, MD, Clinical Medical Director, and Nenaya Omeribo, Assistant Medical Director, MD2. The Chief Medical Officer was chosen because he is involved in defining the overall business strategy and direction of the organization, while the Clinical Medical Director was selected for her role in medical supervision and involvement in every process that may interfere directly or indirectly with the quality of situation. The Assistant Medical Director was selected for the role in supporting the implementation of medical policies and ensuring the delivery of quality patient care. These different professional interviewees underline the need for collaboration with various stakeholders in the development of the Select mobile app. They contended that such an app is critical since most information technology has had a significant impact in the delivery of care in healthcare settings. The information provided by this professional were utilized since it enhanced my knowledge of mobile information technology and development of various aspects of the mobile app. The proposed mobile app is My Family app. The app was developed on the premise that it's important to integrate health it's very important to integrate health literacy into the development of My Health apps. Accordingly, or additionally, the app was developed on the basis that health literate apps have the potential to improve the quality and usefulness of health information for all users, leading to better outcomes. This app will help improve access to and use of health information on mobile devices by providing new possibilities for engaging with everyone with necessary information for managing their health. My family app engages users in managing their family's health by incorporating the My Health Finder widget, which allows users to access tailored covered preventive services and recommendations for each family member according to their age, gender, pregnancy status. The app users can then engage with this content by saving priority information and creating personal calendar. The family app also allows users to share information via social network. Innovativeness of the proposed solution. The proposed solution is innovative since it's based on the concept of My Health, whose access and use has increased in recent years. Moreover, it is a better solution that meets new requirements. More Americans are using mobile devices to access health information than ever before. Mobile devices, which include smartphones, tablets, and internet connected devices, represent a rapidly growing market. The solution also utilizes mobile application software that helps to improve access to health information. As mobile devices become more passive, mobile health application software presents an exciting new opportunity to improve health and wellness. The proposed solution is innovative since it's based on some principles of innovation, including intersection, which entails combining different concepts across different disciplines. In this case, the proposed solution effectively integrates concepts in health and information technology. The proposed solution is also innovative in the sense that it improves access and use of health information as well as affordability and accessibility to healthcare services, which is one of the roles of disruptive technology and business model in innovation. Finally, these are my references. Thank you very much for listening.